Good morning, everyone, and welcome to the Thyro Multidisciplinary Seminars. I'm Mark Kirkin from New York, but we have a very exciting and really terrific panel this morning. This is going to be our very popular tumor board program that's going to be hosted by Dr. Michael Tuttle. We encourage everybody to send in your questions. And we will get to as many of these as possible during the 1 hour session. And I just want to make a quick note that next Friday, because of the American Thyroid Association meeting in Washington, we will not have a live program. So with that, I'm going to turn this over to Michael. And again, we encourage you to send in your questions.
Thanks very much, Mark. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center in New York. And it's my great privilege just to ask questions this morning. I don't have to know anything, so that's the fun part of doing this. I'm going to go around our presenters here and ask if you all can just introduce yourself, and we'll finish with Dr. Trevor, who's with us from the University of Southern California, that's going to present the cases this morning. Dr. Hartl, we'll start with you.
Hi, I'm Dana Hartl. I'm a surgeon at Gustave Roussy Cancer Center in France.
Fantastic. Dr. Thomas from down under.
Yeah, hi, I'm Liz Thomas. I'm a nuclear medicine specialist from Perth in the west coast of Australia, and I have a special interest in both pediatrics and adult nuclear medicine, with particular thyroid cancer.
Fantastic, Liz. Dr. Ghossein.
Hi, I'm Ronald Ghossein. I'm a head and neck pathologist at Memorial Sloan Kettering Cancer Center.
Thank you, Ronnie. Frank.
Hi, I'm Frank Worden. I am a medical oncologist at the University of Michigan, and I specialize in head and neck oncology and endocrine tumors.
Awesome. Dr. Langer.
Hi, good morning, everyone. I'm Jill Langer from University of Pennsylvania, where I'm the chief of ultrasound and co-director of our thyroid nodule clinic.
Thanks, Jill. Dr. Roth.
Hi, I'm Mara Roth. I'm an endocrinologist at the University of Washington and the director of our endocrine tumor program at the Fred Hutch Cancer Center.
Fantastic. Dr. Angell, we'll let you multitask, introduce yourself, and pull up your slides at the same time.
Perfect. Thank you, Mike, and really appreciate the invitation to be here and do some cases. Yeah, my name is Trevor Angell. I'm an endocrinologist at the University of Southern California. I'm the associate director of our thyroid center here, and we're affiliated with the Norris Comprehensive Cancer Center and the Safety Net Los Angeles General Medical Center. So if for anyone out there who happens to not know where Los Angeles is, this is the current map. You can see us here still in the dark. So like many others, but some people may be like me, not enjoying the sun on our cheeks yet. So the light in my sky is my cup of coffee here for the next little bit. So no disclosures, and I'll just jump right in. A 52-year-old woman with a thyroid nodule initially palpated by her primary care provider. She doesn't report any previous history of any thyroid abnormality, but since hearing about this new finding, thinks some of her symptoms may be related to her thyroid. She doesn't have any compressive neck symptoms such as dysphagia or positional dyspnea. She does not have a hoarse voice. And otherwise, she's healthy, takes no regular medications. Her family history is negative for any thyroid cancers or other malignancies. And on review of systems, she does report some fatigue, thinning hair, brain fog. She doesn't have any flushing or diarrhea. On physical examination, she's well appearing, she's healthy. On palpation of the thyroid, there is a left-sided nodule, roughly 4 to 5 centimeters perhaps, and with swallowing, it's perfectly mobile. A palpation of the rest of the neck doesn't reveal any adenopathy. And performing a TSH test, that comes back very normal looking at 0.73.
Okay. Dr. Roth, these are common things that come in, although 4 or 5 centimeters is getting a little bigger than normally walks in the door. What are you thinking about the case? How are you sort of thinking about this right now, Maura?
Yeah, well, we see palpable thyroid nodules pretty commonly in the general population. Often patients are walking in because they've had a nodule picked up incidentally on a scan. But when someone has a palpable nodule, certainly we want to evaluate with a neck ultrasound and understand what this looks like. The fact that she has no compressive symptoms despite the size is very reassuring because that gives us a sense that this has been growing fairly slowly over time. And so sometimes with a nodule this size, it may actually be visible when the patient walks in the room. So occasionally I'll ask patients if they've seen this on in the mirror or if they actually have old photos where they can see that to give us a sense of the time course.
Dr. Hartl, you're a surgeon. She's 52. This is 5 centimeters. I assume she's going to surgery, correct? Unmute there, Dana.
Yeah, sorry about that.
Okay.
I know, not necessarily. I think as years go by, I'm more and more conservative about this. And if it were, we're going to, of course, go to FNA on this. If it were benign, and benign looking on ultrasound, a low grade of whatever score you're using, and she's asymptomatic and you can't really see it, I would discuss, pros and cons of surgery with the patient. I wouldn't necessarily go in on a benign nodule just because of the size. Plus, we have other options as well nowadays with minimally invasive thermal ablation techniques. So if it were benign, not necessarily.
Yeah. Dr. Langer, if I called you and said, I've got a young lady, because by my definition, 52 is still young, 4 centimeter nodule, I need to take a look at the thyroid, the neck. What imaging study should I pick, Jill?
Yeah, so ultrasound is definitely the first step in terms of characterizing the subtle features of malignancy. Ultrasound far and away is the best imaging modality. And also what should be part of every neck ultrasound is a thorough assessment of the lateral cervical lymph nodes, which would then not only inform but guide further management decisions.
Now, as they get bigger, Jill, do you automatically start thinking about CT, or are you still comfortable with ultrasound at 4 or 5 centimeters? Anything about size that pushes you?
Yeah, I mean, so if a patient were presenting with stridor or some sort of symptoms and so forth, CT would be the better modality to evaluate tracheal compression or invasion of the trachea. But really, other than that, I don't feel as though CT offers any advantage.
Gotcha. So in the absence of some sign or symptom of structural invasion, we're probably going with ultrasound to begin with. Okay, Trevor, even though you're from California, I assume we did a normal evaluation here and stuck a needle into this or did an ultrasound. What'd you do next?
Yeah, absolutely. So the patient did go on to have an ultrasound and trying to give representative images, obviously limited to a couple. This is what was found.
Now, Jill, this is the most unfair thing we ever do, but God knows people email you these pictures all the time and ask you to look at them. For a first look on these 2 pictures, what are you thinking?
Yeah, so we have the transverse view of the right lobe, which looks normal in background parenchymal echogenicity. And then fairly obviously in the left lobe, we have this 4 to 5 centimeter, nearly entirely solid, hypoechoic nodule, sharp margins, but does have the feature of macrolobulations. There are scattered echogenic foci in there, a couple of which are sort of clustered. There's no gross macrocalcifications. Just looking at a nodule that is solid and hypoechoic, we're already talking about a 40 to 50% likelihood of malignancy. Certainly this looks like it's a neoplasm. There's nothing about this which would look like a typical hyperplastic nodule.
Use the term macrolobulation, Jill. I don't know tell me about that.
So when we look at the border of a nodule, we could define it, first of all, as distinct or indistinct. If it's distinct, then we can look to see if there are jagged, spiculated, irregular margins. And that, particularly in solid nodules, is a very good predictor of malignancy. If the nodule is solid and it has sort of large undulations or macrolobulations versus microlobulations, which has gotten a lot of brouhaha lately in the ultrasound literature, which is basically defined as little lobulations under 2.5 millimeters, people have made a distinction that is more predictive, the microlobulations as compared to macrolobulations. One of the things, though, when people discuss that finding is they're not specifying, are they talking about a solid nodule or a mixed cystic and solid nodule? And I think that's really important. If we have a solid nodule such as this one, and it has some undulations, to me, that is a neoplastic growth pattern.
Gotcha. Dana, as we're thinking through this, 4 or 5 centimeters, if this was going to be a cancer, does the absence of having abnormal lymph nodes with something that size make you think cancer, not cancer, type of cancer? Does that factor into sort of how you're thinking about it?
Well, I would definitely be looking at the lymph nodes very, very closely, and we systematically have a new ultrasound done in our specialized center before going into surgery, or a workup for any malignancy. But there are lots of thyroid cancers who don't have a propensity to have give out lymph node metastases, such as follicular carcinomas. So no, that wouldn't necessarily surprise me.
Got it. Okay, Trevor, what do we do?
So, of course, the patient did undergo fine needle aspiration biopsy. The result of that was Bethesda category 6 malignant result, which was also stated to be positive for medullary thyroid carcinoma.
Well, there you go. Dr. Roth, I'm sure you told this patient, don't worry, it'll be maybe a cancer, maybe benign. We might not have mentioned it might be medullary. And so now it's Friday afternoon, you got the results back and she's calling for the results. What are you going to tell her on the phone about this biopsy?
Well, so I'm going to explain to her that this is a positive result. Well, first of all, when we discussed her ultrasound, we'd probably talk about this being in a higher risk category. But certainly medullary thyroid cancer is not the most common result that we have on a fine needle aspiration. This is still, in general, can have very positive outcomes. And if it's a sporadic medullary versus genetic orientation with a positive RET proto-oncogene, then the outcomes are a little bit different. Usually we would start here by getting genetic testing for this patient. And so we'd want to get that RET proto-oncogene tested to see if this is part of a multiple endocrine neoplasia syndrome. And we'd want to get a baseline calcitonin and possibly a CEA as well to help with our preoperative management.
Gotcha. Ronnie, it seems like most of the medullaries that I see, the FNA doesn't call it medullary. It says spindle cells or it says atypical. I know you're a pathologist, but cytologically, why does that not always get called, or those descriptions there, Ronnie?
Yeah, you're completely right. Medullary thyroid carcinoma at the FNA level and in the surgical pathology specimen is probably the most underdiagnosed malignancy for very banal reasons, because it's very rare, especially in non-academic centers. Even physicians in their 50s and 60s haven't seen one for years, and they're not used to the typical features, which are spindle cells, or plasmacytoid cell, binucleated cell. So they call it often follicular, suspicious for follicular neoplasm, and they don't think about doing a calcitonin stain. Yeah.
Hey, Frank, I may be getting a little bit ahead of the cart here, but Mara talked about doing germline testing, but if the germline testing doesn't show the RET gene, when should we be thinking about doing somatic testing on tumors like medullary? I mean, everybody up front, or only when they have distant mets? Where do you think that should go into that, Frank?
Yeah, as the medical oncologist, I got to get my money's worth, right? Since we're not talking about drugs yet, which is, as I think about this, we do have a study that we have open about RET positive patients giving neoadjuvant treatment. So, one could consider that now. As the medical oncologist, we're, not so interested until, we're called into play. And usually that's with metastatic disease. So I don't know that that's necessarily going to change the management right now, but I don't think it's wrong. I think there's more of a movement in thyroid cancers these days, to check next generation sequencing. But the question really comes in, what do you do with that information? And I think it really goes back to the surgeons, at this point to continue the treatment strategy.
Got it. So we probably wouldn't do somatic testing up front on every medullary, but if it was one of those presentations where we were thinking about neoadjuvant or something like that,
correct,
we'd want to know the target. Okay,
correct.
Good. All right, Dana, this is obviously a surgical issue sort of thing here. So pre-op evaluation, and then kind of what surgery are you planning here, Dana?
Well, the pre-op evaluation, we need to get plasma calcitonin levels on this patient and CEA. And then work her up. If usually the germline RET testing, at least at our institution, takes a while. So we are going to treat, I mean, do a workup as if it were endocrine neoplasia, a syndrome, MIN syndrome. And so we'll be doing calcium levels and looking at urine metanephrine,
right.
At least to rule out pheochromocytoma and added thyroid adenoma or hyperplasia. That'll change also the surgical strategy. So that's the workup that we would do, and then the surgery would be based on as per many guidelines that are out there that are based on some large studies that have been published a while back, and we really indebted, I think, to Henning Drahl and Andreas Machens and the German group to have really spelled out, at least for what we know today and what's in the guidelines then, is surgery based on the calcitonin levels. And so it would really depend. She'd get a total thyroidectomy because that's also in the guidelines. And given then probably given the size, I would expect the calcitonin to be kind of high. If it were above 500, we would also be doing workup to try to rule out distant metastases, or at least find distant metastases before we went in surgically. We tend to do morphologic imaging with a head and neck, chest, abdomen CT, and liver MRI, and at least a skeletal MRI. And then the surgery is going to be total thyroidectomy, probably a bilateral central neck dissection, but that again is going to be depending on the calcitonin levels, and then the extent of neck dissection is really going to depend on how high that calcitonin is.
Yeah. So what if I push back just a little bit, Dana, in terms of the extent of surgery? Assume this is germline negative. You're only seeing the medullary, maybe some lymph nodes on that side. Our Japanese colleagues have done lobectomies for medullaries for many, many years. And I know our Bible says we're supposed to do a total, but can I ask why? Why couldn't we just do a lobectomy here, Dan?
I think that's a great question. I really do. And there's also a Spanish group that published a very interesting study last year where they showed that the cutoffs for having neck nodes in the different levels was different between sporadic and germline related medullary thyroid carcinoma. And so they showed that the levels, the cutoff levels were higher for sporadic lesions. And I was even wondering if the somatic RET testing wouldn't give us some information about maybe the biological behavior of some of these diseases as well. So maybe depending on the somatic RET mutation, we're going to have more indolent disease. So it's a great question. In what cases can we do less? I think that's, and I know when I'm in there and I'm taking out a normal looking thyroid lobe for medullary thyroid carcinoma, I'm like, well, why am I doing this? For sporadic medullary thyroid.
And Ronnie,
So
years ago, there was like a retrospective study that showed in people that were apparently sporadic, 2 or 3% still had a medullary in the contralateral lobe. In your experience on the sporadics, do you often see something in the contralateral lobe, or is that only in the germline, or can you tell?
Yeah, so in my experience, I really do not see usually a tumor in the contralateral lobe. What you may see if the tumor is aggressive, you may see foci of lymphatic invasion in the other lobe that may be mistaken by some pathologists as a multicentricity. Gotcha. But in my experience, no. If you pay really attention, no.
Yeah. And Trevor, let me put you on the spot here, because I've thought a lot over the last several years about why we're automatically doing totals on all these. How are you sort of thinking about this, Trev?
Yeah, I would say that I really sort of have approached it historically, with aggressive surgery in mind, and as you were mentioning, other literature in terms of the outcomes and pathologic, literature in terms of how often do we find contralateral things, have just started to get me scratching my head. Really interesting to hear Dr. Ghossein saying there about, if there is mention of, contralateral disease, what is that really? I guess the question would be, if it is, areas of lymphatic invasion, does that mean something different than multifocality in our minds in terms of the need to resect, or even though it's something to distinguish between, should that still push us towards needing to get rid of that contralateral tissue?
Gotcha. Dr. Erkin?
Yeah, a quick question from the audience, Mike. And this really goes to Jill about distinguishing between a complex nodule versus a solid nodule with cystic degeneration. Jill, can you touch on that?
Yeah, and so I think that the literature is really sound, and there's uniform agreement across all risk stratification systems that when you have a solid and hypoechoic nodule, it is highly likely to be a neoplasm of some sort, mostly malignant. A subset of those will be benign. I think the analysis of a mixed cystic and solid nodule is perhaps the most challenging that we do for a variety of reasons. It's very, very subjective, and the findings in mixed cystic and solid nodules do not necessarily correspond to the same findings that we would see in solid nodules. So for example, taller than wide shape is very, very robust in solid nodules. It's not that robust in mixed cystic and solid nodules for a variety of reasons. And so this is actually a challenge across many of the risk stratification systems as to sort of codify what the findings are in mixed cystic and solid nodules that are suspicious. There is the prototypical appearance of a cystic papillary, where you have an excrescence or a nodule that has multiple echogenic foci and calcifications and a regular interface between the cystic and solid components. But beyond that, I think it's really a continuum of findings that becomes very challenging to codify.
Got it. Okay, Trevor, so we'll go ahead. So just for the listeners, still in medullary, I think the standard operation, at least in the United States, is total and central neck dissection. But lots of us are beginning to ask, are there specific ones, as Dana framed it, that maybe wouldn't need all of that, but still standard of care by the guidelines now? Trevor, people were asking for imaging and some lab values.
Right, so let me go forward in terms of what went on with this patient. So there was initial biomarker testing done. Preoperative calcitonin level came back 14,973, which is just a little bit high with an upper limit of 5.1. And for what it's worth, the CEA also done at 242, with normal being less than 3.
Perfect. Pause for a second. Liz, when we get numbers this high, we're clearly thinking likely outside the neck and distant mets. And, they're not always, but that's where we're thinking. What kind of imaging were we thinking of, particularly sort of, functional imaging that may be helpful for us here, Liz?
Well, we've got a few different functional imaging techniques available to us, depending on where you are and what agents you have at your disposal, which is often what dictates practice at most centres, unfortunately. I mean, I think F-DOPA has the highest sensitivity of all the functional imaging modalities. I think it's superior to both FDG and dotatate PET, and really should be considered in those patients with high or very high calcitonin levels. And I think 500, in a preoperative setting would be a good level to trigger further evaluation. The problem with F-DOPA PET is it's not universally available. It's actually a very difficult synthesis, and it doesn't like being transported. So then you're left with a dotatate PET, which has a reduced sensitivity and lesion detection rate. FDG PET also has a role, particularly in those with more aggressive tumour types, particularly in the post-operative setting. If you see someone whose calcitonin may be increasing rapidly, then you could consider FDG PET, and often we do end up doing more than one imaging, using more than one imaging modality to get a really good understanding of the biology of the tumour.
Yeah, I think from a practical standpoint in New York, if we saw this, we would probably CT scan neck, chest, abdomen, and pelvis just as a first look, not functional imaging with us. Looking for big stuff is probably how we would start. What'd you guys do, Trevor?
So she did have a dotatate PET, and I realize the text on this slide might be misleading. So there was a finding in the thyroid that was 6 by 4 by 3.5 centimeters and had avidity with a SUV max of 29. There were no additional lesions, no metastatic sites identified.
And I would assume that would be good. Like Liz, if the primary tumor grabbed onto the dotatate, we would expect probably the distant mets as well.
Yeah, I think that's a reasonable assumption. You know, usually metastases have a similar profile to the primary tumor, not always, but usually. So I'd be fairly reassured with that.
Okay, we're still.
And Mike, I just want to add one thing. We may also consider even an MRI of the liver if the lesions were so small and weren't detected or picked up on PET, or if we are concerned about an aggressive picture, even doing a CT or an MRI of the brain to look for the rare but occasional brain met.
Thanks, Frank. Because what you hear is, Liz, is we're just distrustful of your scan. That 15. That 15,000 is distant mets until proven otherwise, right? I mean, that's the flavor here.
Well, one of the issues with dotatate PET is you do have a lot of background liver activity, less so with F-DOPA. So I think if you don't have F-DOPA and you're doing dotatate PET, then yes, definitely would do an MRI of the liver as well.
Okay. All right, Trevor, let's look at the path and the surgery and see where we go.
Yeah. So path momentarily, I will say the patient did have plasma metanephrin assessment for hyperparathyroidism as well, you know, because of patients, the sense of urgency and some financial stuff, you know, the germline testing was not done preoperatively. So as was said, we just got the testing.
So his surgery, the patient's surgery was total thyroidectomy and central neck, I assume, Trev?
Total thyroidectomy at central neck, and actually had some limited extension of that, as you can see on the ultimate results.
All right, Ronnie, this looks like a storm front coming into me on the Weather Channel. Can you help me explain what this is?
Sure. You can give me some time. So basically, what we see here, if you focus on the middle kind of medium power, you see a tumor that is growing in solid nest. And this is the most common histologic phase of medullary thyroid carcinoma. Actually, we tell our fellows every time they see a tumor with a solid growth to think about medullary thyroid carcinoma. And as I said before, some pathologists even miss histologically this, and I get cases asking me what it is. So the diagnosis has to be made, in my opinion, with the immunostain. Some pathologists, when it's a typical picture like this one, will make a diagnosis without immunostain. I think it's extremely dangerous. And the stains work very well, calcitonin, CA. Of course, you have to do also the negative stain, thyroglobulin, and so forth, because sometimes Hartl cell can pick up calcitonin. It's a false positive. I've seen a case who ended up as actually a lawsuit. Now, there is, in addition to the diagnosis, what are really the features that make a big difference here? We did a study 2-3 years ago, and its study was done at the same time as an Australian group at Sydney, led by Anthony Gill, an outstanding endocrine pathologist. And contrary to a lot of what was said, especially by the German group like Dr. Drale, fibrosis, for example, doesn't play such an important role in, I just remind you that in Germany, they do even a frozen section, Mike. And if the frozen section contains fibrosis, they will do a total thyroidectomy. Really, this doesn't work. And the best proof is that it didn't work in our center, and also it didn't work in Sydney, Australia. So how now there are not many prognostic factors in medullary thyroid cancer, but there's new one that everybody should know, which is the grading system that we devised at the same time as the Australian group, and we published a paper in JCO, Journal of Clinical Oncology, with the multi-international group, including the Gustave Roussy group outside Paris. So basically, it's very simple. You should ask your pathologist to give you the grade that is based on mitosis 5 and more, a Ki-67, very proliferative index, which is very easy to do. Any lab can do it all over the world, and the presence of tumor necrosis that is very important. And lastly, I will stop. We just got a paper accepted in thyroid. Mike, of course, you're on it. We wanted really to see, because Dana was talking about the prognostic power of RET mutation. So we really wanted to see in the setting, not in the pre-op, in the post-op setting, we wanted to see the value of the RET mutation value and value of any genotypic alteration. And we found out, contrary to Dr. Elisei and the Italian group, that actually the RET mutations did not correlate with disease-specific survival or recurrence-free or local regional recurrence-free survival, only with distant metastasis-free survival. But on multivariate analysis, it fell off when you when you confront it with stage and with the grade. So really, I think grade is a very, very powerful prognostic factor.
Fantastic. Yeah, that's important. So the ones of us that do medullary now have to go back and look at that new staging and grading system. So it's helpful to us. It's pretty well understood. All right, Trevor, take me to the end of this one. Show me the path report and then the post-op calcitonin.
All right. Well, I didn't want to be accused of not giving the pathologist enough to work with, so I made it real close in case there was anything else to say. But if there isn't, we get.
Yeah, this, for example, could be amyloid. I'm not sure, but just the way en passant, I should say that amyloid has absolutely no prognostic value. We used to think that in the past, but yeah.
So pathology in summary was medullary, 6.7 centimeters. It did not show lymphatic invasion, angio invasion, or extrathyroidal extension. Margins were considered negative and didn't have level 6 lymph nodes, and then, as I said, had a couple of lymph nodes that were reported as coming from level 3 and 4.
Sorry, Trevor, can I stop you? Did your pathologist mention any mitosis or necrosis in the report? They have to mention it even if they don't use the grading system. They probably not, right?
If they did, it stuck out to me as low and not something I included.
So it's probably then a low grade lesion. Okay.
And then so T3A, a final stage of 2.
Yep, and the post-op calcitonin.
So came back, actually coming at 1 month, returned with labs had a calcitonin of 10, CEA considerably lower at 12.5. And certainly wasn't convinced, but 3 months calcitonin had fallen to 3.4 again, and then 6 months down to 2.9. Her most recent evaluation was after a year. It had undulated a bit, but remains at 4.9, a CEA of 1.9.
So quite a surprise. I'm going to talk for a second, Trevor, then I want to skip down to case number 2 when we come up. So we've seen this a few times. Ashok Shah, who's our surgeon here, pointed this out to me a few years ago. These large medullaries that almost look circumscribed and no lymph node metastasis will make these tremendously high calcitonins in the 10, 12, 14,000. And when you take them out, the calcitonin goes to really low just a few days later. So there appears to be something different about them. They don't have tons of lymph node metastasis. They're big isolated nodules. And I've followed some of these now for a few years and haven't seen much distant mets. Ronnie, have you seen any, Ashok and I talk about this, any difference in these great big ones that don't have lymph node metastasis?
Look, I didn't, honestly, there's nothing cytologically or from the architecture that is different. Now we tried to see, because you have to understand that medullary carcinoma in general are well defined, Mike, but there is always a little bit of infiltration. Now we looked at the purely encapsulated ones, and we didn't have a lot, but we didn't see encapsulation as a good prognostic factor. But I know that Dr. Ghossein from Paris, who works with Dana, they found in their study that encapsulation has a good prognostic factor. I don't know who is right because we don't have enough cases. So you have to be careful between encapsulation in medullary, which is really rare, and overall well-defined tumor. Yeah, no, there is no way to, I don't see anything special about them.
Yeah, I don't either. It's that clinical thing. While Trevor jumps down to case 2, Frank, there's a couple questions about when do we use RET inhibitors in medullary cancer? So a few sentences about, when we should be thinking about those sorts of medicines.
Sure. So, right now first of all, selpercatinib is the only agent that is available. Pralsetinib was taken off the market, not due to lack of FSC or worsening side effects compared to other RET inhibitors, but there wasn't enough confirmatory data. So maybe someday that will come back. So in terms of selpercatinib, would we consider it neoadjuvantly? As I mentioned earlier, there is a study that Mark Cefario and Maria Cabanez has included us at Michigan as a site. So we are treating such patients. So we don't have data on such yet. In this particular case, listening to Ron, what he's saying about the pathology and the encapsulation, it would make more sense for us to go to surgery. The question could come up, is the surgery going to be so devastating or life altering in terms of quality of life, where perhaps if someone had a RET mutation, somatic RET mutation, or even germline, that we could consider treatment up front, but that would have to be a multidisciplinary discussion. So to answer your question, Mike, really, selpercatinib or RET-directed therapies, or even or multi-kinase inhibitors, are really considered for patients who have metastatic disease and are not amenable to surgical resection for other sites of distant mets.
Now, Frank, occasionally we end up with these folks that we can't find their distant mets and their calcitonin's going 50, 75, 100, and they come in and say, give me something to stop this. Are we to the point we're going to start treating those biochemical numbers, or you still wait for structural disease?
I'll be honest, I have done that. And of course, the patient I did it on because he was desperate. Well, and it was like, actually, to be honest, it was a RET positive, poorly differentiated carcinoma, but this poor guy ended up with all kinds of side effects. So that's what you run into. We don't have data like in an adjuvant setting. So really, to be fair and honest about that question is, no, we necessarily would not do that. I think we'd watch them very closely, their calcitonins, and work with the endocrinologists and the surgeons. But really, without definitive data to support that, that would not be a recommended standard.
Gotcha. All right, Trevor, let's do another medullary. Today is medullary morning. Let's see what you got.
All right. So a 60-year-old man was found to have a thyroid nodule on a pre-employment examination. He had a history of it, DVT-PE, was on long-term anticoagulation, a history of diabetes. Neither of those meant to be secret kernels, just of interest to flush out the patient. He was diagnosed with medullary thyroid carcinoma on FNA. He didn't have any family members with relevant tumors, and on physical exam, he had a somewhat small mobile nodule without any clinical evidence of adenopathy. He underwent a total thyroidectomy and a left lateral lymph node dissection as part of his initial treatment that confirmed medullary thyroid carcinoma. Is 2.4 centimeter, and to what we were saying before, reportedly with micro multifocality within the gland. There was lymphovascular invasion and positive lymph nodes in the central neck, 6 out of 13, with negative lateral neck disease. He did undergo germline RET testing that was negative, and he had initial postoperative calcitonin of 12 a few months after surgery.
Okay, Mara. So now we've got a medullary that's a little more straightforward, typical size, a few lymph nodes involved. And here we are after surgery now. He's not cured because we still got a calcitonin. What do you tell the patient, your expectation, what's going to happen here? Sort of think out loud a little bit there, Mara.
Yeah, so I mean, with his staging, I don't have a preoperative calcitonin here, and then with this postoperative calcitonin and the lymph node involvement, in general, this still can be quite an indolent disease. But he does have a risk of recurrence, most likely local recurrence in the lymph nodes. And so typically we're going to follow with surveillance here, generally every 6 to 12 months, following by neck ultrasound primarily, and the calcitonin and CEA. We would consider additional anatomic imaging depending on what happens with his tumor markers as we go along.
Dr. Langer, the role of ultrasound sort of in the post-op neck, my reports can say anything from atypical to secretly suspicious, or I get an email that says, I'm a little worried about this. Do you guys have any kind of standard language to describe these lymph nodes and how much I'm supposed to worry when you take pictures of all these?
Yeah, that is a challenge, and basically we will give you the size of lymph nodes in 3 dimensions. We will report pertinent positive and negative findings. So the findings that would be considered positive would be a rounded shape, not so much for medullary, but in papillary, any cystic change, any echogenic foci in a lymph node, which is less challenging than in a nodule because they're not supposed to be there any which way. And we'll do a vascular analysis, which I think is very important. In the setting of papillary cancer, we're looking for abnormal peripheral vascularity. In the central compartment of the neck, we are looking for sort of any sort of vascularity, because that's far less common in the central compartment of the neck. And then for the oppression, we try to have 3 results: no abnormalities seen, a finding suspicious for metastatic disease, or indeterminate cannot exclude a low burden of metastatic disease, which I really think is very fair to our endocrinology colleagues to allow them to just carry on with further surveillance.
Oh, it sounds good. Liz, when we're dealing with small volume disease, do any of those functional sort of imaging, so you talked about the FDG PET scan being largely, big tumors and aggressive tumors. Any role for nuclear imaging in this sort of small volume stuff?
No, not really. I mean, we generally reserve, F-dopa PET for calcitonin levels, 150 and above. Similar argument to our follicular-derived thyroid neoplasms. I'm not sure the benefit of identifying very small lymph nodes in the neck and how aggressive you have to be. I think possibly just, if everything's stable, you don't need to rush in to confirm that a small, like a 3 millimeter, slightly suspicious lymph node contains metastatic disease, but be kept under surveillance. But I wouldn't be rushing in to do any functional imaging at this sort of calcitonin level.
Dana, just sort of your management philosophy. I mean, we're zero surprised that there's still a little calcitonin because they had lymph nodes to begin with. Is your approach to find every teeny tiny lymph node medullary and operate on it as soon as you can, or watch for a little bit? How do you think about that, Dana?
No, I agree. With this level of postoperative calcitonin, he had this surgery. We don't have the calcitonin pre-op, but he did have total thyroidectomy central neck and a lateral neck. So no, I think we just want to follow that up. And then nodes, the problem is going back. It's risk benefit. He maybe has a central node, somewhere kind of in the periphery of what was dissected out. And so we are not that aggressive. If we find something that's suspicious, that's 5 millimeters or 6 millimeters, we're going to wait until we do have proof that it's actually growing before sticking a needle into it to get the diagnosis, and even before discussing going in. So no, we're trying not to be too aggressive in terms of morbidity, because as was said already, these can stay indolent and the prognosis can remain excellent in terms of survival. So we don't want to bring in too much surgical morbidity here.
Right. So what's the goal of the surgery? Maura, some of these patients just want a biopsy and they want a surgery. They want it out of their body. That's not a judgment thing. That's just the way some people think. If you end up doing a surgery, what do you tell the patients in terms of expectations? It's going to cure them and they're done, which is what they want, or we're going to keep an eye on it. So how do you frame that, Maura?
Yeah, I really try and dissuade patients from having additional surgery with particularly a low-level calcitonin. And I really talk to them about the risk that, particularly if these are micrometastases, that they're not actually going to be resected. And so there's a high risk actually that they could potentially have more surgery and most often will not have a surgical cure. And that's where I think there's really needs to be a lot of shared decision-making and reassuring patients that this is very common for us to see this low-level calcitonin and even potentially to see small micrometastases remaining in the neck that we can follow for an extended period of time.
Yeah, and I've seen a good number of these folks get a surgery. They find some medullary on the surgery, and then we do the ultrasound 6 months later, and Jill reads it as stable because what we took out wasn't the 5 millimeter place in the scar tissue. It was something besides it. And then some that went to surgery and didn't find medullary cancer. So, you know, when you're dealing with that small stuff. All right, Trev, so what happened with this one? So your initial one was a calcitonin at 12. Where'd you go?
So, you know, underwent ongoing monitoring over time. That calcitonin was relatively stable, you know, between about 10 and 40. And he was undergoing neck ultrasounds to monitor over time. And that showed around a 1 centimeter thyroid bed nodule that looked most likely like thyroid tissue. A needle was stuck in it at some point that was benign thyroid tissue. And otherwise, there were no abnormal lymph node findings in the cervical neck.
Bill, can you, we often get this sort of ultrasound report that says, could be benign tissue, could be residual thyroid cancer, could be scar tissue. Is there a way for you to kind of tell, or you're just describing the local area for us?
Yeah, it can be tricky. So in these medullary patients who have not had ablation, I think it's much more at play that there could be a little bit of tissue left. In patients that have had total thyroidectomy and ablation, really, I think a lot of radiologists are seeing the normal fibrofatty connective tissue that lives in the neck and misinterpreting that as thyroid remnant. I'll look at the op report. Occasionally you do have a patient who has a very extensive tumor and the surgeon will note that they could not get a complete resection and they've left tissue behind. Usually those patients are referred to radiation oncology and are on oral medications and so forth. So I think radiologists are just very confused about sort of the fibrofatty connective tissue, which is bright, not exactly the same, but somewhat similar to thyroid tissue, whereas most residual disease or recurrent disease in the bed is hypoechoic and vascular.
Very good. All right, Trevor, take me through toward the end of this one now.
So, you know, the patient had a change in the velocity of things thereafter, with a gradual increase in calcitonin up to a level of 177. And trying to evaluate that in terms of a doubling time comes out around 3 years for doubling in that sense. So at that point, started to undergo additional imaging. Had CT of the chest, MRI of the liver, and another ultrasound of the neck, none of which revealed anything to us. And then had a nuclear medicine bone scan as the next step in the evaluation.
Okay, I cannot possibly read this. Liz, quick peek of that. This is a pertechnetate bone scan, I assume?
Yes, an HDP bone scan. I'm struggling to read it too, Mike. It's okay. There's a lot of degenerative change in the spine, and we've only got the planar images here. The problem of bone scans is that they're not specific, very sensitive, increased osteoblastic activity, but not at all specific. The changes we can see in the spine and the periarticular activity, particularly at the knees and the ankles and the feet and the acromioclavicular joints, would all be in keeping with degenerative change. I note that there was some minor asymmetry at the right ischium and perhaps at the left anterior iliac crest, but you'd probably want to do SPECT with this to really see whether there's any focal abnormality. We don't often do bone scans in this setting, probably because we're lucky at our institution when we have access to a range of PET tracers. But if there were any questions raised after this and the calcitonin was continuing to rise, we would offer F-Doppler PET imaging.
Okay, and you guys read this as normal, non-specific, Trevor?
It was many non-specific findings. They actually looked at that right iliac site and said that was potentially suspicious. Yeah, I mean, just kind of a note on the practicalities of medicine. You know, insurance. This is what they wanted before getting another test.
But pre-test probability of distant Mets with a 3-year doubling time of calcium 177 is pretty low, right? Those are usually in the thousands by the time we'd find something. Not always, but okay. So let's keep going.
Yep. So now we had this finding that remarked about a potential metastatic site. Obviously, now the patient's in a different state of mind. So did get a functional imaging study with dotatate PET scan. This is another snowstorm to me, but tried to highlight where pick something up. So other than this, superior sort of neck finding, going down through the bones, there was nothing else that was abnormal at all.
Okay, so no distant Mets and probably something in the left neck there, right?
Yes.
Yeah,
Okay.
about now.
Yeah, now that's good job, Liz. You have to hit the buzzer. Yep. Okay. So obviously then onto an ultrasound to go find this. Okay.
Yeah. So I think the patient was brought in, to our center, had ultrasound done, with potential to biopsy, identified more abnormal looking lymph nodes in the low neck, and underwent FNA that was positive.
So Dana, assume for me this is kind of left paratracheal. We'll make it central neck, which is where they often are, just left paratracheal somewhere. So now it's been biopsied, and you mentioned when you were talking before, don't biopsy unless you plan on doing surgery. That gets the train running and kind of hard to stop. So what do you tell this patient about sort of surgery, your expectations? Can you watch one that's biopsied? You get these referrals. So how do you think here?
Yeah, that's a great question. I think it's really going to depend on the size of this lymph node. Like was said earlier, very small lymph nodes are really hard to find. So if we really, really want to go back into that neck that's already been operated on, we may use some colloidal charcoal tattooing there, ultrasound guided tattooing before going in, when we've really discussed the need to go back in. I think it's a really risk benefit. The patient needs to understand that if we remove this, that the calcitonin levels aren't necessarily going to even go down much, or might go down a little bit, but it's not going to be something that's it's very unlikely to cure him. And then it's in the central neck, so we have the current nerve that's there, and really there is a high risk for postoperative recurrent nerve paralysis, temporary for sure, permanent also. So the patient really has to be aware of the risk benefit of going back. And I would probably get a contrast enhanced CT also before going back in, just to see where that is in terms of the esophagus, trachea, and the tracheoesophageal groove.
Right. And Jill, can you speak to that a little bit? Because our team tends to do the same thing. We tend not to operate just on an ultrasound and in this recurrent setting. What additional information does like CT with contrast or MRI bring to us?
Yeah, I think the anatomic localization. So with ultrasound, some lesions can be hiding, particularly in the TE groove. We know that from all of our parathyroid patients, that's a real hiding space. Ultrasound also, again, as before, would not do as good a job for tracheal or esophageal invasion. Sometimes lesions that sort of are wrapping themselves around the carotid sheath space can be very challenging for tumors like this. So I think that when surgery is planned, really the CT map is very much more valuable to the surgeon.
Yeah, we often get faced with either little recurrent disease in the neck, or whether it's medullary or papillary. And we sort of talk about 5 things that we think about. What makes us move from watching to surgery? We talk about size. We talk about location, right? Because sometimes small things in bad locations need to be treated. Size, location, rate of change. Not the tumor marker, but the nodule itself, right? How quickly is it changing? Is it causing symptoms or likely to cause symptoms? And then the last one is patient preference. It sort of gathers those together there. All right, so Trevor, so this one, she ended up having surgery?
Yeah, he ended up going back, having a lymph node dissection again. Yes, it was in the central neck area. The size on ultrasound was around 2 centimeters or so, and they went back a little bit into the neck and found, you know, sort of what they called multiple nodules or you know, replacement of lymph nodes with disease. He came back quite recently after this with postoperative calcitonin, now maybe back to the baseline, but not negative, and did very well. Didn't have any even temporary complications, fortunately, and you know, this was where he had sort of been for many years, was very motivated and is happy that he's back to this place, which is good for all of us. But, you know, kind of seeing where this calcitonin will go now.
This is what Mara was talking about. Hey, Dana, for the non-surgeons in the audience, when you go back to take out a lymph node like that, I mean, we have the picture, you just go find it and pluck one out. What really happens when you're in there? And you guys always seem to take out more than I knew about. So, you know, we won't tell anybody. Can you tell us what really happens in the operating room when you're hunting down one of these little places?
In the central neck, it really depends on what has been done initially. And often we don't really have the operating report, or it's not very detailed of what had been done before. But yeah, generally speaking, we go back. If the central neck hadn't been completely dissected out, we go and try to redo a whole central neck dissection. But it's really hard though, because it's fibrotic. You can't even really see these nodules. If it's 2 centimeters, I might be able to palpate it. I might be able to see it, but often they're sort of in this fibrotic tissue. So that really what we're doing is we're going in and we're taking out whatever isn't vascular, nervous, esophagus, and trachea. And maybe if we see a parathyroid, we might want to try it, but that's really tough to find parathyroids in re-op surgery. So really we're limited because of the just not being able to dissect into this fibrotic tissue, if you will. It's like I tell my residents, it's like dissecting in your table. It's hard like wood. So I guess I hope that answers your question.
Yeah, it does, exactly. Yeah, it's a different picture than we
It's
had.
not easy.
Frank, there was one question from the audience that was the same as what I had, because when Trevor presented this case, the patient had a DVT. Some tumors do make folks hypercoagulable. You know, in the small papillaries, the small medullaries, I don't think I see DVTs, but anecdotally in the bad medullaries, I think I do. From your, I mean, you see a lot of these distant mets, not only in the medullary, but in like the poorly differentiated. Do we need to worry about hypercoagulability, Frank?
You know, in this, I'm not sure that I thought the same thing, and I was wondering about that. I guess you could say, you know, cancer is an inflammatory state, which would put you at higher risk for DVT. In this particular case, I agree with everything that's been discussed, that it's taking on a more indolent approach, and this gentleman can probably live for years being managed and, you know, with local, you know, treatment, etc. So, you know, the question comes up really, is this a person that should be on lifelong anticoagulation, is kind of what you're asking, because they have cancer. And the answer is we don't know. The hematologist will tell you we don't know, because the patient does have cancer, and we do know that there's some underlying degree of cancer living at this level of 17 or whatnot in the neck, that to be on the safe side, you know, did the DVT, you know, predate the tumor? Perhaps that it probably does, now that we have DOACs and people are not having to undergo injections with Lovenox and things like that. It probably does warrant continued treatment versus someone who should be treated for 6 months and stop therapy.
Right. But in the absence of the history of a DVT, we don't routinely put our distant metastasis folks on that, right? We'd be looking.
Absolutely not.
Yeah.
No. Even people with aggressive tumors, no. We would wait until something occurred. Yeah.
Got it. Well, we are right up against the hour, team. You guys did a great job. Trevor, thank you so much. These were great cases. We sort of talked about a wide spectrum of medullary here. And thanks for the panelists for answering a bunch of questions that didn't really have answers, but thinking out loud and thinking about how we're dealing with medullary now and how we're dealing with it in the future. So thank you all. And I wish everyone a wonderful week. And we'll see you on the next meeting in 2 weeks. Thanks now. Bye-bye.